I'll start with our first panelist, representing dentistry, David Van Appledorn. Dave, tell us a little about yourself.
Dave Van Appledorn. I've been a Holland resident most of my life. I went to Hope College, graduated in 76. And from there, went to U of M and graduated in 1981. I've been in dentistry for 42 years and retired about 3 years ago.
Dr. Bryan Drozdowski.
So Bryan Drozdowski, grew up in the Detroit area, went to University of Michigan for undergrad, Wayne State University for medical school, got my MD in 2001, went back to University of Michigan for my internal medicine and pediatrics training. So that's 2 residencies in 4 years. I don't remember it. And then I moved out to greener pastures with my wife, who's also a physician in the area, dermatologist, Barbara Drozdowski. We settled in Allegan on some acreage and have been out here for 20 years. I practice at Lakeshore Internal Medicine and Pediatrics with my partners, Greg Scrotenboer and Tricia Miller.
Dr. Jane MacPherson, palliative care.
Hello. I went to, well, I'm from Ionia. I went to medical school and undergrad and medical school at Michigan State and did my residency there in family medicine. And practiced in Michigan for about 7 years and then moved to Utah, where I shifted into hospice and palliative medicine, which I did for 23 years out there, and then retired and moved back here and been retired 5 years now. So anyway.
Lastly, our swimming specialist and ophthalmologist, Dr. Bryan Huffman.
I'm Bryan Huffman. I grew up in Hudsonville, graduated from Hudsonville High School, and then did my undergrad, medical school, and internship all at University of Michigan. And actually, Dr. Drozdowski and I did our internships together at St. Joe's Hospital in Ypsilanti. And then I went down to University of Florida for my residency. And I've been with Sight Eye Clinic here in Holland for about 20 years now with Dr. Bast and Dr. Luschner, my 2 partners there.
Okay, now you know the players. I forget you, Doug?
Yeah.
How can I do that? I had to twist his arm to do this.
I'm Doug Walvoord. I guess I'm a fill-in. The price was right. I'm a 64 Hope grad. From there, I went to Northwestern Medical School in Chicago for urology, well, medical school, and then a urology residency definitely after that. In 74, came up and started practicing in Holland and moved up here. Most of you know my wife, Kay, who has been head of the Holland Symphony better than you know of me. Retired in 2008. And interestingly, I've told some of you this, but when I retired, my children got together, all chipped in to buy me a HAS membership because they were sure it was essential to save our marriage once I was going to be home all the time. So happy to be here. Thank you.
Now you know, you all knew Doug anyway. I would ask that you write your questions down and send them forward. And I will ask the questions of our panelists, but I will get the ball rolling with you, Doug. I want to give us a quick review of the UTIs, urinary tract infections. Brief.
He didn't tell me about this ahead of time.
Then you wouldn't have done it.
I mean, we could spend hours talking about that. I mean, it's from a simple bladder infection to life-threatening kidney infection, even some prostate infections with sepsis. Many of them happen innocently. Many times there are structural issues. People have kidney stones associated with infections. John, that's such a huge question.
I can narrow it down for you.
Well, why don't you let the audience narrow it down and see what they come up with?
Any questions? Right there. We need a microphone over here, please. Do we have one?
No, we've got
We have one. We were hogging them all up there.
What are the common causes for UTI?
That's almost as broad as John's question. I mean, where do I start? I mean, there are innocent infections. Who hasn't had a bladder infection, especially if you're a female? Prostate infections occur as men get older. There's obstruction, stone issues. There's the whole category of infections you might catch. We won't really get into that right now, but you know, the serious ones involve the kidney or the prostate, where sepsis is a potential part of it.
Let's narrow this down to stones. What's the most common ways that stones are eliminated?
You're really picking on me here. Well, the most common way to get rid of stones is to pass it. Most people do, and that, of course, is better. And you know, and of course, we're talking about stones. It's a big variety of compositions, reasons you form them. Many stones are small, passed down the ureter, and the size of the stone may be inversely related to the discomfort. I mean, they say it's worse than having a baby, and I fortunately never had either one. But you know, but of course, we can get into all the various technologies and going after stones from below, or lithotripsy, the external stone crushing. And, you know, since I started in 74, the whole nature of stone treatment, it just changed incredibly. I mean, fortunately, very few people go under the scalpel for stones these days compared to the old days. And it's wonderful. Yeah. Worry with stones, of course, is damage to the kidney. An infection behind a stone is a very serious situation.
Do you have a?
What causes the infection with enlarged prostate? I've had that, and it was very bad. So I was just wondering, is there a way to avoid it? Is it unavoidable?
Boy. This is, yeah, oh, this is great. Well, obstruction, of course, is an issue. If you don't empty your bladder completely, you're just like any pond that doesn't drain completely, sediment and potential infection. But just enlarged prostate, the prostate gland, the ducts don't drain as well as they should. That's an issue. You know, do infections arise from above or below? Usually, I would say from below the urethral obstruction. But an obstructive prostate is more susceptible to infection, obviously. How do you avoid it? Don't let your prostate get enlarged. And so that's not a serious answer, but you know, urinate frequently, you know, get ahead of it. You talk to your physician. He may send you to a urologist. There may be times when surgery is needed because of blockage. You can get stones in the prostate too, but not necessarily directly related to infection in most cases. Wally.
Yes, Doug. I'd like to know, is there any diet you can use to avoid kidney stones?
The best diet for kidney stone is to drink a lot of liquids, drink a lot of water. Dilute urine is the best defense against stones. But, you know, recurrent stone formers need to be worked up, see how much calcium they excrete. Well, you're stretching me here. I wish this were 18 years ago and my memory was a little better. But, you know, most stones are calcium oxalates, the most typical find time. And everybody worries about milk, calcium tablets and so forth. But the oxalate component may be more important than the calcium. And the oxalate component relates a lot to how your GI tract recycles the oxalate and you have the bile acids and all of that. So.
If you don't mind interjecting, Doug, please. So primary care, it's very heavily, at least as an internist, you know, toward the the whole spectrum of life, also a pediatrician, but I see plenty of UTIs. And they present in a lot of different ways. Just a couple tips and things to remember. One is if you have a spouse or a loved one or somebody that you know elderly, and they're confused, they're not acting the way they should, their memory's off, they're a lot more fatigued, and they have no urinary symptoms, it could be a UTI. Get the urinalysis. Recent research does show that low sodium diets are key for a lot of people, especially I think calcium oxalate at reducing the amount of stones, reducing the stone burden. Hydration is important for everything, unless your cardiologist tells you otherwise. And the thing about UTIs is you might actually have bacteria in your bladder. It doesn't necessarily have to be treated. It's asymptomatic bacteria where your doctor says, you know what, you're not having any symptoms. You just have bacteria there. Treating that bacteria over and over again just breeds resistance. And that's something that we don't want to see.
Randall.
Doug, you mentioned that it's very seldom now that someone goes under the scalpel for kidney stones. What has changed?
Well, in terms of kidney stones, the lithotripsy, the shockwave lithotripsy, you all kind of know what I mean. A focused shockwave breaks up the stone within you to multiple small fragments that you can pass on your own. Now, that's kidney. And of course, huge stones are a different story. And infected stones are different than others, and what the stone composition is. And certain stone material breaks up easier than others. Then we get into stones. Once you start passing it down the ureter, it's a different ballgame. And when I started, small stones down lower in the ureter, you can look in the bladder, the guide safety wire up, go up with a little very gentle basket thing and just very gently remove that stone. Then they developed tiny ureteroscopes, very narrow, long scopes, where you could look up the ureter. Well, that would get us up to the lower third, maybe the lower half of the ureter. Then they developed flexible fiber optic scopes, which amazingly very small scopes allow you to very nicely visualize the whole urinary tract up into the kidney. And with fiber optic laser fibers, you can safely break up a lot of stones this way, even within the kidney. So it makes huge difference. And if a patient presents with infection, you can take them to a cystoscopy, put a guide wire up, put a stent up to temporarily drain the kidney, get the infection cleared up, and then safely go ahead and do that. There's just so much to say here. Percutaneous approaches, that also is still used, but probably less now. But put you on your side, put a scope in under fluoroscopy, gain access to the inside of the kidney, and with scopes there, go in and break up the stone and remove the fragments. Very complicated question, but you kind of get the idea. To come a long way. So much better for the patient. So much quicker out of the hospital. A lot of times outpatient procedures.
As you know, with research, trying to stay up to date with that, we're always, in medicine, asking questions. Are we doing the right thing? Are we recommending the right thing? It used to be that, oh, these are calcium stones, so we should reduce our calcium in our diet. That actually increases your stone formation by your body saying, okay, then I'm just going to grab it from the bone and we're going to make more stones. So that is an example, and we see this all throughout medicine still to this day, where something that we used to think is actually the very wrong thing. You should be doing the opposite.
Oxalate's the word.
Do you have any more questions about kidneys, or do you have a question for another doctor up here? There's many to choose from. If not, I'm going to ask one again. Dr. Huffman, you're on. With cataract surgery and then lens replacement, is it very common for an artificial lens to form a film similar to a cataract? And if so, is it treatable?
So yes and no. It's not actually the lens that forms the film. So the lens itself should outlast all of us. It's made out of acrylic, essentially plastic. It lasts forever. It's very rare for a lens itself to get opacified. I've never had to remove a lens because it got hazy. But there's a membrane that sits right behind the lens in the eye. So when we do a cataract surgery, your natural lens in the eye is surrounded by a membrane called the capsule. And you can think of it like a plastic bag suspended in the eye that holds the lens. And when we do a cataract surgery, we tear a hole in the front of the capsule and remove the hazy lens that we call a cataract, but we take great care to leave the rest of that bag intact. The back of that bag is very fragile. It's 4 microns thick, so about a 20th the thickness of a hair. And we don't want to break that. If you touch it with something sharp, it'll break. There's things we can do to deal with that, but ideally we don't want that. When we put the new lens in, it fits right inside that natural bag, and that's what holds it in place. That's why I don't have to sew the lens in place in the eye. And then what happens is as it heals over a few months, that bag kind of shrink wraps around the lens and locks it in place. The back part of that membrane is intact, which it should be. It's typically nice and clear after the cataract surgery, but over time, in most people, about 2/3 of people, it'll start to get hazy. It's kind of scar tissue and debris build up on it. Most of the debris is actually residual lens cells. We can't get every cell out, and they will actually proliferate and try to grow a new lens, which they are never successful in. They just make junk on that bag. And then it starts to get hazy, and you'll hear people talk about their cataract came back, or we used to call them secondary cataracts. It's not a cataract at all. The lens is fine. Your old lens is gone. You can't get a cataract again, but that bag gets hazy. And when it does, it's a very simple treatment. It's a 2-minute procedure in the office with a laser. We take a laser that we focus in on that membrane, and every time I fire the laser, it makes a little tiny hole just in that little membrane, and we connect them kind of like a plus shape. The little flaps pull out of the way, and then the membrane's out of the way, and you have a nice clear view. And then there's no membrane to get hazy again, so it's a one-time thing. And 2/3 of people will need that, most commonly about 3 years after cataract surgery. Some people it'll be right away. The membrane will haze over pretty quickly, or just wasn't perfectly clear right after the cataract surgery. We give it enough time to heal and then do that procedure. Some people never get it, but it's a simple thing. Usually when people come in, we notice it, we treat it right the same day while they're there, because it literally takes 2 minutes, painless, not a big deal.
Thank you. Back there. Oh.
Thank you. Is the goal of cataract surgery to restore a person's previous prescription or to get something better?
So the goal of the cataract surgery is to get rid of the hazy lens. That's the primary goal. So as the natural lens in the eye gets hazy, it becomes like looking through frosted glass, and the glass just keeps getting more and more frosted. If you leave a cataract, indefinitely, eventually you go blind from the cataract because you're just looking through eventually it turns kind of brown in color and is completely opaque. We don't wait that long here in the United States. Typically, as soon as it gets hazy and starts bothering you, we take it out. But the primary goal is to get the hazy lens out of the way, because when you're looking through that hazy lens, there's nothing I can do to clear that up. Just like looking through frosted glass, you can't focus to make that view clear, so I can't fix it with glasses. Once the lens is out, then I can clear things up with glasses or contacts or whatever. But a nice side effect of the surgery is when we put a new artificial lens in, we can put whatever strength lens we want. And so we can set your focus to be wherever you want it, essentially. And what most people will pick is to have good focus for distance and then reading glasses for up close. With a regular lens, I can do just the opposite. I can make it so you see up close, but then you need glasses for far away. We sometimes do one eye of each, one distance, one near. And then there is newer lens technology nowadays where we can try to do both distance and some near at the same time. With what's called an extended range lens, it warps the light as it comes in to give you good distance, but also to add more up close. The closer you try to get, there are also lenses called multifocal lenses that get closer, and you start having trade-offs with distance. So it's a matter of talking with the patient, find out what their goal is. Still the most common lens I put in is just a regular lens for distance and then just reading glasses for up close. But some will elect to have lenses to try to give them more up close vision as well. There's extra cost to those, and that's probably the main factor for most people.
Okay, years ago, my parents took me to Niagara Falls. And I think 8 or 10 years old. And they said, Ralphie, you want to go see the cataracts? So how did we go from a rapid water to a thing in your eye?
So you're correct. The Latin meaning of cataract is waterfall. And so, yes, you will hear that term used from times for waterfalls, for flowing water. And the thought was back in ancient times that what your cataract was kind of like a waterfall. It was fluids in the body that were now not clear, and that's what was making things blurry, that you were looking through a waterfall in the eye, and that's what was distorting the vision, and that's where the name came from.
Okay, I have two questions. The first one is there any treatment for macular degeneration? And answer that, and then I'll have another one.
Well, there are lots of treatments for macular degeneration, but some of it depends on the specifics. So almost everyone gets some degree of dry macular degeneration over time, where you start to lose some of the little light detecting cells in the back of the eye. Most people will stay the dry type, about 80% will. And that progresses over time, but very slowly, over years to decades. So most people don't get to the point where they have big vision problems from that. The main treatment for dry macular degeneration is vitamins. It's called the AREDS2 formula. And it helps to slow the progression of macular degeneration by about 25%. And it helps to make it about 25% less likely that it will turn into the wet type. So everybody starts with the dry type, about 20% will go on to wet macular degeneration. And what happens then is little blood vessels grow in to that same area of the retina where the center vision is. And those vessels initially start to leak fluid, which will cause things to look distorted and blurred. Ideally, we want to catch it at that point or before, because the next step is it leaks blood. And when it leaks blood, blood is toxic to the retina cells when it escapes the blood vessels. And so it starts killing off those little light recepting cells in big bunches of them. And there's no way to get those cells to come back once they're gone. With wet macular degeneration, we can treat that. In the old days, we do laser treatments to destroy those vessels, but it would destroy all the light recepting cells in the same area. So your vision would get worse, but it would prevent it from getting worse yet, which wasn't a very great selling procedure. People weren't very excited about it. But nowadays we have medications that can get those vessels to shrink and go away. So you'll hear about people having injections of this medication. They're medications that inhibit vessel growth, and they get those vessels to shrink and go away. If you catch it really early before it's bled, the vessels will go away and we can restore vision to what it was before they went to the wet type. If it's bled already, we still get the vessels to go away, but the damage is already done. And once those cells are gone, we can't get them back again.
All right, so is the little dip, that's what I was shown.
Yep.
What is that?
That is the fovea. So nowadays we can take, it's kind of like a CAT scan of your retina, but it uses light, where we can take a cross-sectional image of the retina. So we take a picture, and it's kind of like you took the picture, and right where light is focused, right in the middle, we cut it right in half and tip it on its edge. So you're looking at a cross-sectional view of the retina. And in the very center part of the retina, right where you're focusing at, there's a little dip where the cells are, the photoreceptors are more concentrated, but it lacks the cells over top, so you have better vision there. So that's what you're seeing. That's the very center part of vision is what you're looking at then.
Well, what does that mean for the future?
Yep, so that dip should be there.
Okay.
That's the fovea. What happens in macular degeneration is the deepest layer of cells in the retina are the cells that detect light, the rods and the cones. And those cells are what are damaged by macular degeneration. And those are the cells we can't get back. So the whole key is trying to slow loss or prevent it. But once they're gone, we currently don't have a way to grow those back. And that's an active area of research. If we can figure out how to grow new rods and cones, there's stem cells or things, then we can start restoring vision. But right now, all our treatments are to try to prevent it from getting worse, or really to try to slow it getting worse.
So you're telling me I need some type of treatment to stop this?
Well, I don't know all the details
No,
specifically,
but I mean, generally.
So in general, people that we see that come in with dry macular degeneration, it's vitamins to treat it. And then people that have wet macular degeneration, it's doing these injections to keep these little abnormal blood vessels gone. We treat it, the vessels go away, but then the medication wears off and they want to grow back again. So it's a matter of treating it over and over again to keep them gone once they're gone, to try to slow the progression as much as we can.
Okay. My second question is, how do you repair a botched surgery where they made for cataracts, they made the pocket too big, the thing slipped out?
It's hard for me to answer that without all the details, but
Right.
there are things that can happen in cataract surgery where we have some kind of problem. So that membrane I was talking about earlier breaks. That's probably the most common problem. And then the lens you don't have a good spot to put the new lens. And we have ways to deal with that in the surgery. I always have 3 lenses ready to go in the eye. The main lens I tend to put in, a lens I can put in just in front of that bag if the bag is broken, and a lens I can put in front of the eye if the entire bag structure is no good. And so we can oftentimes repair that at the time. If you have a lens that later on, if that support structure looks okay, we put a new lens in it. There are several conditions that cause that support structure to not stay good over time. And then a lens can fall out of place, which doesn't happen real often, but it does. And there are ways that we can either remove that lens and put a lens in the front of the eye that doesn't rely on that support structure, or you can actually sew a lens in place in the eye called a sutured IOL or intraocular lens. So there are ways we can fix that. So fixing the lens itself and putting a new lens in place, we have technology to do that. What tends to be the bigger problem is if there are other problems like macular degeneration or glaucoma. Those problems we can't always fix, but oftentimes we can do something for the lens itself.
Okay, I will have to come and see you.
Question back.
So if you have dry eyes, does that lead to dry macular degeneration, or
Nope.
is that not a progression?
Common confused thing there, but they're 2 different things. So dry macular degeneration, the only reason we call it dry is because we don't have those abnormal vessels that are leaking fluid, but it's a process of damage to the retina and the very back of the eye. Dry eye is a problem with not having a good tear film on the surface of the eye. And more than half of people I see in a day have some degree of dry eye. You could almost say it's normal.
Going to lead into it.
Correct. If you have dry eye, that doesn't mean you're going to get dry macular degeneration. They're totally separate things.
We'll change the subject a little bit here, maybe to get some of the other doctors involved. Recently, I saw an article about a lady that lived to be 117, and her secret, and it may be a one-off, was she was eating yogurt 3 times a day. But my question is about bacteria in the stomach and the effect of yogurt on that, and just have you comment on that topic?
That's internal medicine, I think.
That's quite internal. My wife is external medicine, but so we're talking about the normal gut flora. We're talking about what's called the gut biome, which there's a lot of research there. It seems just a burgeoning field. a lot of interest in that because we're seeing the types of gut biome, basically how healthy your intestines are, how much of the healthy bacteria you have, for instance, the lactobacilli and other beneficial bacteria, and seeing and equating that with health, decreased inflammation. When you do something to damage or destroy the normal gut flora, then you run the risk of having extra inflammation, and then perhaps something that is that skews into a little bit of the quackery, but with every bit of quackery, there's some truth, but you do have some leaky gut that can happen. So you no longer have the integrity of your intestinal lining that you used to have. And you do worry about some transition of some of the things that need to stay outside of the body being transferred inside of the body. So you start seeing potentially some more inflammatory conditions, autoimmune conditions, just generally feeling unwell. So what are some of the things that can destroy your normal flora? Well, an antibiotic can. While antibiotics are important, antibiotics are great for taking care of a multitude of illnesses. And in fact, you, in many cases, can die without one. We have to be judicious about the kind of antibiotics that are being prescribed. If you can go topically, that would be great for an antibiotic. But if you have to go with an oral antibiotic, you want to make sure that you ask your doctor, well, is this going to kill everything? Is this kind of focused on this one area? We start with a generally focused antibiotic. If it's a skin infection, we will treat with an antibiotic that generally just treats that and doesn't go head to toe with going to all the other areas necessarily. But when you start getting the broader spectrums, killing a lot of the bacteria, well, your natural bacteria are going to die with that, right? So that is an interesting field, and we need a lot more research in this. What I can say as a clinician is you're on this antibiotic. This is going to be one that takes care of your gut flora and kills it. You want to do something like a probiotic. If you don't take one a day. If you already take one, take 2 a day. You want to make sure that it's as short of a course as necessary. And if you have, an infection that is a few days long, it's nasal congestion. We all know this. Back in, 30, 40, 50 years ago, people wanted an antibiotic for it. And that's why we don't have amoxicillin working for respiratory infections as much. We don't have the Z-Pak working that well for infections anymore. You can go down the list. We have a whole series of resistant bacteria that require more and more heavy antibiotics, but that does, as I had mentioned, not only create other issues with resistance, but it can take care of the flora. So yogurt was the question. Is yogurt a good thing? Yes, yogurt's a good thing. I usually recommend something like Activia. There are all kinds of yogurt out there, but increasing that intake would probably be a good thing.
One of the things I remember from medical school is you think of your body as mostly being your cells, but actually bacterial cells are much smaller than human cells are in general. And you think of, not having bacteria all over, but your skin is covered with it. People think about, a staph infection's a terrible thing. Well, your body's covered with staph. Every time you get a cut, it's usually a staph infection that usually heals just fine. But our bodies, if you look at the total number of cells, and I don't remember how many cells we're made out of anymore, but I'm going to make up a number of 1 billion. It's 4 times as many bacterial cells. So you are like 1 billion cells and 4 billion bacterial cells that make up your body, because they're all over your skin, the inside of your gut, everywhere.
Can you address C. diff? And how prevalent is it? And can you ever get over it?
So C. diff is short for Clostridium difficile. It's now been changed, as a lot of things have in medicine since med school. It's now Clostridoides difficile, but it's still C. diff. C. diff is more common than you think. You probably have heard of somebody who has had C. diff. That is when you have killed enough of your beneficial bacteria that this Clostridium starts to grow and divide and start to take over in your gut. It used to be called antibiotic-associated colitis before the causative agent was known, until it was discovered that this bacteria that forms this toxin takes over, and this toxin forms a horrible diarrhea. It is, for most people who have had C. diff, there's a certain consistency, smell, intense diarrhea. It's frequent. You can actually get toxic, septic, and die from it. And it almost always is associated with a particular antibiotic. There are some antibiotics that are higher on the list of potentially causing it and wiping out the flora, and then some antibiotics that are not as common of a cause. The broader the spectrum, the greater the chance that you're going to kill off your good flora and end up with the C. diff in its place. The trouble with C. diff is that it doesn't respond to typical antibiotics. Before, we used to use an antibiotic, metronidazole. That doesn't work much anymore. We use vancomycin, which is oral, high dose, that takes care of it in maybe 50–60% of patients. There is another antibiotic, 2, 3, 4 months later, it comes back. Then you have to treat it with vancomycin for a longer period of time. The most recent research, and one of the treatments to get rid of it, and it is curable, but it does take a fecal transplantation where you get an NG tube placed down into your gut, and you actually give donor feces down into the NG tube, which is one of those areas of medicine that we still use leeches, by the way, and maggots, but it does work, and it helps restore that natural flora, and can indeed be curative.
Ralph?
Jane, maybe you could talk about coordination of treatment across, various doctors. So, for example, I've got VA benefits, but I see a personal doctor also. How do you coordinate that so that one doctor knows what the other doctor's doing?
Give her a microphone.
I'll repeat that. You have to have a telephone. That is the best way. I mean, theoretically, with electronic medical records, the whole idea was there would be a portability of these records from one place to the next, and that we could, as physicians, access those records from anywhere. But we have not arrived there yet. Some states are better than others. Utah actually had to put together a database where you could do that. But I haven't heard or seen anything here yet that's quite that sophisticated. But on the other hand, there weren't as many hospital systems in Utah either, so they get a pass for that. But I think it's a challenge, because if doctors don't talk to each other, a lot of bad things can happen. I don't know so much with ophthalmology versus your internist, but when it does get very complicated if you're seeing an oncologist and a nephrologist and your primary care doctor. All of them should be in the loop. We try to send records to each other, but I don't know about you guys' experience, but to me, the new EMR, electronic medical records, are often very sterile. So you don't sometimes get as much of the picture as you might if you were just talking to each other on the phone. So, you want to ask your doctor, will you call my other doctor and talk to them? And yeah, it takes a few minutes, but usually you can get communication between doctors pretty quickly. I think. I don't know. What's your experience with it, Bryan? I mean, do people talk to each other around here?
Oh, we do. We do, absolutely. It's helpful when consultants put in a cover letter, or just like right away, these are the bullet points, because sometimes they'll get an ophthalmology note that, has a lot of jargon in it, but I know right where to go for Bryan's notes and cardiology. I mean, like this is the take home. There are usually a few lines in there that say this is this is what it is, this is what we're treating, this is what to expect. They're going to be seeing you in follow-up, or they're going to be seeing the ophthalmologist in follow-up. So that we get that communication, but there is urgent communication, and I don't know if we utilize that as much. Yeah, I'm always on the phone with the emergency room physicians. Hey, your patient's here. Can you help me out with him? When was the last time they did a stress test, for instance? So that human touch, that human communication is something that we are indeed losing. I think sterile is the great term for that. I think it's going to get further sterile with the advent of AI, when you may not even see a professional. You may end up putting your symptoms into some database and then spit out, like, you have to do this first before you even talk to an individual.
That's really a tragedy of medicine, I think, when we come down to that, because disease is usually more than what the algorithm is going to take you to, because you're a human being and it's more complicated than that. And when we don't talk, if the doctor doesn't listen to their patient, and I really am a big believer in face-to-face visits. I actually think telehealth is fine, by the way, because you're still face-to-face. But I think when you get too many layers, then the translation of the question or even the symptom is lost between your phone call to the front desk by the time it gets to the doctor. That makes sense. And yeah, cover letters are nice, but I wasn't seeing so many of those when I finally retired. It was like, well, just look at the EMR. But that may be the downside of having access to the EMRs, and there are cover letters anymore. And so sometimes it's a little bit of you have to have almost some intuition to understand what they were really thinking or where they were going to go next, because it tells you what the diagnosis is and the next plan, but you don't know a lot of other information that might help you either not step on the specialist's toes or just help the patient have a better quality of life, which was kind of my job.
There is a burden with inbox. Every time we walk in, we have maybe 20, 30, 40 notes to review. And each one of those notes are now 4, 5, 6 pages of all of the stuff. So it's nice to go to that take home message. But that can be fatiguing, going through all of that information, just all the data that we have to process in a day. In fact, there's some offices, we don't have this, but there's an actual inboxologist who's an advanced care practitioner, an APP, or a mid-level physician assistant nurse practitioner, who just kind of goes through these things and kind of takes out the important stuff and puts it into the patient's chart. And it's hard to have that breadth and width and depth of patient knowledge when you have to, sift through all of that information. We are seeing a little bit of that. There is a synopsis, and it's pretty cool. We just got this maybe 2 weeks ago. This is great. When I see a patient, I'll actually see a synopsis of their inpatient care, their specialty care, all the things that have come into the office electronically, medication changes, some pertinent labs. So that saves us a lot of time.
We have a question in the back.
Yeah, I have a comment and a question. I completely agree with you about seeing a doctor. I used to work for IBM before I retired, and we had Watson 15, 20 years ago that was doing AI in medicine, but seeing a doctor is a whole different. But my comment on that is, nowadays you see a deputy nurse, a nurse, a physician assistant, it takes an act of God to actually see a doctor. So I'm all with you. I'd love to see my doctor, but 90% of the time I don't have a choice of that. So if you could comment on that. And then a question that I have is acid reflux, especially in younger people. My niece is 25. She's been to lots of doctors and has acid reflux. What's the cause of it? And I know supposedly diet can help. Could you give some guidance around acid reflux?
Well, Yeah, and I'm sorry you don't get to see doctors, and that's a whole different discussion, really. I saw you taking a breath like you were going to comment on that, but it is sometimes rather frustrating for sure. Acid reflux or GERD, sometimes referred to, it happens because at the end of your esophagus, as you're swallowing, just before it gets to the stomach, there's supposed to be a valve. And the valve is supposed to close after you're done swallowing, and that keeps things in the stomach from coming back up. There are lots of different things you can eat that make that valve weaker, dietary wise, chocolate, peppermints. You know, sometimes actually things that people tell you to take if you're having indigestion actually do make that valve more lax. And then age related, it gets lax, and some people actually develop anatomical abnormalities where the valve is not in the abdomen and it's up in the chest and the valve won't work. So on a younger person, it might be something dietary, but obesity also can make that a problem. I've read several times that a lot of gastroenterologists say if people just wouldn't eat after 6 o'clock at night, their business would drop off precipitously as regards GERD. And it might be really true because fatty foods also relax the valve. So there's a lot of behavioral things that make that worse. And then when that acid that's supposed to be in your stomach gets into the esophagus, that's when it burns, right? And then if it repeatedly gets up there, then it burns and damages the tissue, and then the valve can't work right. So it's really a vicious circle of insult to that area of the stomach and esophagus where there's a juncture, and that can actually lead to cancers too. So, you know, it's not like you want to just ignore it. And Bryan probably has more to say too.
So I'm just thinking about something that would be applicable for everybody. You guys have all heard of a hiatal hernia. That is the presence of the stomach that's pushed up through the diaphragm. So now instead of that valve, that sphincter that should be closed, it's kind of wide open. You end up with basically a free passage of acid that goes right through there. I'm not sure if that's your loved one's situation, because somebody in their 20s is quite young for that kind of a reflux situation. It does happen. If weight loss, the proton pump inhibitors like omeprazole, Prilosec, Protonix, Prevacid, those medications aren't working, or if you're just tired of taking those, you can do a surgery. You can bring the hiatal hernia down and then kind of cinch the part of that diaphragm so it doesn't come back up. You can also take part of the stomach and loop it around the base of the esophagus to create a new sphincter called a Nissen fundoplication, and they do that laparoscopically. That's decently common too. Couple things I want to say about reflux GERD. If you have hot flashes and don't know why, that might actually, or sweats in the middle of the night, that could actually be silent reflux. I see that all the time. People who are sweaty in the middle of the night. And why am I sweaty? Because you're lying down. There's a greater free flow of your acid getting out of the stomach back up into the esophagus. You may not even feel that acid, but your body responds with sweats. So that's something to talk to your doctor about, or consider just taking omeprazole over the counter. The other thing is a cough, a chronic cough. That's one of the most common causes of chronic cough. You think about, well, postnasal drainage can cause chronic cough. Asthma can cause it. There's some certain medications called ACE inhibitors that can cause it. But reflux can cause a chronic cough. And you're like, I don't even have the heartburn. No, but it's irritating the vocal cords enough where you're getting those symptoms.
Might actually see that if you've been on a proton pump inhibitor like Prevacid or Prilosec, but you're still refluxing, so it triggers the cough. And hoarseness is another common. Sure. GERD is another common reason of hoarseness. People come in and say, I'm hoarse all the time, and it turns out they're refluxing. Night is the most common time for reflux. I mean, not that it doesn't happen in the day, but.
Another thing that's quite often seen in dental offices, the erosion. Is erosion of the lingual tongue side of the teeth. I've seen it quite often, and it is associated with GERD reflux. So people may not know that they actually have it. You tell them and they say, what's that from? Well, you've got it. You better have your physician checked out.
a real common question that I get is, can I take Prilosec or omeprazole for greater than 2 weeks? I hear that all the time. It says it on the package. Don't take any longer than 2 weeks. The reason it says that, it's not that it's not safe for more than 2 weeks. It's, we don't want you treating an ulcer on your own for greater than 2 weeks. We want you to go in. If this stuff isn't helping, go see your doctor. That's the take home with that. We often recommend these proton pump inhibitors, PPIs. Some of you may know, there's some research showing that, boy, could there be kidney problems with Prilosec? Could there be dementia, memory problems with Prilosec and those kind of things? We're seeing, it's like the whole Tylenol during pregnancy. There's some association there. It isn't necessarily causative, but we're looking into it. What I find though, that is if you have uncontrolled acid and it goes on for long enough, that can lead to changes in your esophagus that could eventually lead to cancer, esophageal cancer. That is augmented if you are a drinker and a smoker. But if you take these medications, the risk of dementia, kidney disease is dwarfed by the potential benefit of not developing that cancer in your esophagus.
We have another dental question. For you, Dave. What attracted you to dentistry over other health professions? Part one.
Well,
Start with that.
first of all, my father was a physician. I didn't like the hours. So, yeah, right. So that kind of ruled that out. In college, I thought maybe I'd go into grad school and become an ecologist or a biologist, something of that nature. And well, family got in the way of that. And then besides, I figured I'm not a very good teacher, so that would probably be out. When I was a young teenager, I was hit by a ski pole across my front teeth in my bedroom. Just laying on my bed, got up, and he whacked me in the head. So I spent many hours in the dental chair, and I really got to know my dentist well. Liked what he did. He was really great. And that kind of opened the door.
Well, part two, I'm going to refine this a little bit. How has dentistry changed over your career? That's pretty wide open. Let's change that a little bit. How has tooth replacement technology changed from least sophisticated to most sophisticated? Available now.
Okay. Least sophisticated would still probably be a denture or a partial denture. And not, if you had to grade those out, that would probably be at best a C-. Next, and probably a little more recent, would be a bridge, although there are indication that bridges were used a couple thousand years ago by the Romans. But anyway, a bridge fixed in place by shaping two adjacent teeth to a space and placing a solid chunk in between, cemented in place. That would probably rate B+. So it's getting good. It's nice and firm. Subsequent to that, now we have implants, which are artificial roots and teeth. You do not have to touch the teeth on either side of the space that is of a missing tooth. And it works really well. Drawback of it is the implant is made out of titanium, sticks very well to bone, but the gum around it does not adhere yet. They're working on that. Without that nice, tough collar of a gum around that implant, it is potentially vulnerable if you're not doing your homework.
Thank you. Do we have any questions from the audience? Oral hygiene. I can answer that one. Yeah. In dentistry, we call non-flossers job security. Smokers too, by the way. Wally.
Thank you very much for all five of you. It's a miracle to see a doctor. Now we see five of them together.
Seven.
Seven. Oh, yes, one. Okay, sorry, the other two. I have a question for Doug, Dr. Walvoord. The survival rate for metastatic prostate cancer is improving. Can you make some comments on what are the recent changes in the treatment of metastatic prostate cancer?
No. I'm serious, Wally. I mean, that has changed a lot in 18 years. I mean, everything from chemotherapy to immune therapy. I mean, well before my era, there was hormonal manipulation with estrogens, which were dangerous for men in terms of heart disease, or Lupron, other medications to turn off the testicles, if you will, or surgically remove the testicles. I mean, those are old treatments. Now, maybe physicians beside me may even know more about the oncologic treatment for metastatic disease. I really, I'm not afraid to tell you. I mean, this is great, and I hope I'm never a consumer of that question. But you know, I'm closer to that than I am answering your question. So
in primary care, we follow, it's not the greatest test in the world, but it's the prostate specific antigen, the PSA. You've all heard of the PSA.
I was going to congratulate this group for not bringing that up.
Because the research on PSA changes all the time. I think the American Urological Association and most other professional organizations agree that there's benefit in some cases to following the PSA. Sometimes there's getting a baseline. This is your PSA. This is where yours is. And then we can track it. Sometimes not even every year, just doing it every so often. And we actually detect an increase. PSA is going to increase because it's an antigen, or basically a glycoprotein that's secreted by the prostate that everybody has. If you have a prostate, you have PSA. But every male has an increase in prostate size. So if you don't want your prostate to get bigger, well, you know, that's not going to happen. So it's going to, but prostate increasing in size is a nice linear increase usually of the PSA. You start to see it go up just a little bit. What we're looking to catch is that real sharp increase. We usually say 0.75 in a year. Then we start thinking, okay, this might be a prostate malignancy that's doing that, as opposed to just your normal prostate that's doing that. And once we see that increase, then I rely on my urology colleagues to make a comment on that.
In 1974, when I started, there was no PSA test. It just seemed like a gift from God when it came along. So this is great. Well, as he is saying, I mean, it just the circle came around, and it led to a lot of unnecessary and dangerous treatments and so forth. And when do you start getting PSAs? You know, if you're African American or you have a family history of prostate cancer, yes, you should get PSAs. And again, in general, it's reasonable to monitor them. But when you get in your 70s or 80s, if your PSA is pretty normal, there's not much point in doing it. If there is an issue with your prostate or you've had an elevated PSA, again, I'm not practicing, but I would say, yeah, keep monitoring it. And as long as we're on this subject, when do you keep doing digital exams of prostate? No guy likes having that done, okay? But that was gospel when I was in residency. I'm one of the rare guys who I have to ask my doctor to check my prostate. I mean, I think it's still very important to do that. And during my career, I have diagnosed numerous prostate cancers in men with normal PSAs. And there's the whole issue of bound versus unbound PSAs. I'll tell you a secret. I looked this up on AI this morning just because I knew somebody was going to ask me about it. But again, there's a ratio of unbound to bound, which may be helpful in determining the significance of the PSA. And just very briefly, I don't want to monopolize this, but the whole issue of MRI of the prostate gland, which essentially was not done, certainly wasn't done in Holland when I was there. It's gotten to be very important, and a lot of information can be gained from the size and consistency, what your prostate looks like, you know, if any lymph nodes might be involved. But that's a good test for avoiding more dangerous tests and more unnecessary treatment of men with elevated PSAs.
We have a question in the back.
Done.
Oh, Marilyn's got it.
Or shout it out and I'll repeat it.
You were going to take that home, were you, Marilyn? Karaoke machine.
I have a friend who's got prostate cancer, and it was unknown to him until recently. And apparently it's stage 3, but alleged not to have metastasized, but close. And so he's getting what's called a Tulsa procedure, which with I'm unfamiliar. And apparently that's a more recent technique to treat prostate CA in an attempt to 2 things. Number 1, remove the cancer, and number 2, mitigate side effects with loss of bodily functions. So can you comment on the Tulsa procedure?
Your question is the first time I've heard about it. We were not doing such a procedure in 2008 when I retired.
He was stated that a surgical procedure with what kind he's got has got about a 70% success rate. Radiation 70, surgical 80, and Tulsa Pro 90% allegedly. My dad had prostate CA and he didn't last long at all. And I don't know, he did have metastasis though.
It's an extremely complicated subject because it's sort of like if you figure if what your age is, I'm 82, there's probably 82% chance that you will find prostate cancer cells in my prostate if you take it out and you look closely enough. Well, the vast majority of those men will never die of it, don't need any treatment. So I'm not getting to your question. I'm sorry, because I don't know the answer to that. I never heard of a Tulsa procedure.
Marilyn.
This illustrates a good point, though, with the number of choices we have with being able to treat individuals with prostate cancer. They can, in many cases, just elect to not do anything. We're just going to monitor it. We're going to watch the PSA.
Aggressive observation.
Yeah. So we might do an MRI in another year and just see where it's going. We'll check the PSA. So that's the monitoring. But men also have the option, and a lot of them take it and they say, I don't want this cancer in my body. I want this taken out. So they elect to say, you know what, just take this out. But then you have the potential risks and potential side effects of the urinary concerns and incontinence and things after the prostate cancer surgery. Some people say, you know what, I like radiation. We're going to do radiation. There might be some long-term effects post-radiation, but that gets rid of the goals to get rid of the cancer cells and continue to follow the PSA. And if it increases, then we can do radiation possibly again, but a lot of times they do hormonal therapy with that. But that's the Tulsa, I mean, there are some embolisms you can just throw in there to make the prostate, that area get smaller. There are just so much more, I'm sure, than, certainly than 50, 60 years ago.
It's changed a lot for sure. And I was going to say too, I mean, I don't know, I'm not familiar with the Tulsa procedure either, but I would say that many times if there's an advanced malignancy, it goes to tumor board, which I know, they have them for urology and pulmonology and those are really useful when you go back to coordinating care with your question there, because then you actually have all the specialists in one room talking about all the potential strategies you could take for this particular malignancy with this particular nature. Because some are indolent, like he was talking about, which means slow growing, not going to be a problem. Others are aggressive and you've got to get aggressive quickly or you're going to have troubles. And I think that's an invaluable thing. And doctors do get together for those. They might not see their patients, but they go to tumor board. And usually they'll be in a hospital tumor board almost every day of the week for some specialty. pretty common.
Marilyn?
You can interpret this in any way you want, but my question or my statement is, help me make it through the night. I have constant interruptions. I cannot sleep through the night. I get up at least 5 times through the night. What can I do? Is that mental, biological, both?
More and more, I mean, we've always given people medication for that, and that does kind of work until it doesn't work anymore. So that's the limitation of giving people various sleep aids. And I mean, there could be lots of reasons because sometimes people are up to urinate and then you deal with that. I mean, so you do want to specifically deal with the situation if you can, but postmenopausal women are much more prone to disrupted sleep cycles. And of course, elderly people have a changing sleep cycle too, which actually is more fragmented than when we were younger. So, we talk about sleep like a baby. Well, I don't know about you, but my baby was up a lot at night. So, so there's that. But the evidence actually is strongest for something called cognitive behavioral therapy, to help your mind settle and to get you back to sleep. And there's actually programs, you're talking about AI, you can just, order, I think one of them is Calm. I mean, there's a lot of different programs that you can use. And strangely, they are as effective as most medications, at least especially for long-term use. So, Ambien or something like that might help you here and there a couple nights in a row. But if you do that every day, day after day after day, you're going to develop a tolerance to it. And I'd have people coming in going, well, I take 20 milligrams. And I'm saying, well, that's way higher than any that I'm supposed to prescribe, and I'm not going to do that, So anyway, it's a challenge though, but I think just keeping an open mind to look at ways that you can cognitively manage that wakefulness and how you get back to sleep. I don't want to say mostly mental, but I think you can use your mind to get back to sleep, and I'm not, the sleep-wake cycle is complicated. I mean, maybe you have sleep apnea, you don't fit the bill particularly, but that will wake people up too. So periodic leg movements. So you could do a sleep study. They've gotten a lot more sophisticated and greater capacity to even do it at home. But I would say, at least in my experience for women, disrupted sleep at night is not an uncommon complaint. And, when the hormone levels drop, all that that used to be nice about having hormones is now gone. So anyway, Bryan, did you want to add something?
A lot of questions about medicine, medical therapy for sleep. Now, if you've gone through, as Jane had said, all of the potential medical causes to find out why you're not sleeping. We had mentioned reflux before. We had mentioned, how about urination? Many urinary complaints. People are waking up. There are other kinds of pulmonary type things, lung things, sleep apnea. But if everything else has been ruled out and you just have a primary sleep disorder, then we do get into some of the medications. Now, some are safer than others. The first one that a lot of us recommend would be the melatonin. So basically 3 milligrams, 5 milligrams, 10 milligrams. You can go up to 10 milligrams and be very safe with that. And it has no side effects other than potential sleeping and no interactions with other medications. So that's one of the top line. I even recommend it for my little kids who are having an issue. The over-the-counter sleep aids, the antihistamines, aren't great. They can have some anticholinergic effects. They can have some early morning hangover effect. And you do worry about maybe some cognitive or some memory situations with that. So I don't recommend like the Unisoms or the Benadryls for that.
I was just going to add, when he says anticholinergic, what that means is that you suddenly might not regulate your blood pressure as well. So you're more at risk for falls when you use these like Benadryl and those kinds of drugs, not to mention dry mouth and dry eye and other issues. But it's the dangerous part about it is at our age, we don't want to get up and then fall over on our way to the bathroom. So just
the melatonin is not short term. You can do that long term. The over the counter ones, the antihistamines ones, I don't recommend. Unisom, Tylenol PM, Advil PM, I don't recommend those. unless it's just for as needed. The other long-term one, and we do see a lot of benefit from this, is something called trazodone. Trazodone is a medication you can do 50 milligrams, 100 milligrams, 150, but it has a very good safety profile and can keep people asleep all night. And it's not one of these hammers like Ambien or Lunesta or Restoril or like Xanax, Ativan. Those medications, we like to use those for as needed jet lag. We like to do that for just a temporary period, because as Janet said, I was going to mention the increased risk of falls. You can get up in the middle of the night, not know what you're doing and not remember what you did in the middle of the night. Do I have patients on Ambien? Yes. And I try to decrease the dose if I can, and then switch that over to as needed. Excedrin PM, the way that works is that, so Excedrin is acetaminophen, aspirin, and some sort of a Benadryl product. So it's an antihistamine, which would be okay if you wanted to use that just for as needed. If you really needed that night of sleep and you were having an issue, you can take that. Just remember, you may be groggy in the morning with that, and you don't want to make a habit out of it.
Isn't my area of expertise, but one thing that sometimes can be helpful with this is there are a lot of smart watches nowadays that will track things. My watch actually tracks my sleeping, and it tells me when I was awake and when I was asleep, how deep a sleep I was in, tracks my breathing rate so it can detect sleep apnea, checks my heart rate variability while I'm sleeping. There's all kinds of different things that they can check. And sometimes you're waking up at night and you don't even realize it throughout the night, or you're having apneic episodes. And certainly you can get a sleep study for that. But it's actually amazing how much these little watches will detect. And sometimes that can provide helpful information.
And sometimes I'll see a patient and they'll say, I'll ask them how you're doing. And they'll say, here's my watch. Okay.
We have two more questions in the corner.
I think we have to remember as seniors not to nap during the day. I think more of us nap during the day, which prevents us from sleeping at night. And everybody says, I don't nap during the day. I don't nap during the day. But then you look over and you see your husband's eyes closed. I don't nap during the day. So we got to be careful that we don't nap too much during the day.
And I also want to say, you know, I don't know that this group, well, I would like to think this group isn't as likely to do this, but I know my husband's behavior. Don't be on your phone or your computer late in the evening either. I mean, because that blue light really is stimulating to the brain. And a lot of people now get up, you know, I mean, in the old days, you'd get up and read a book at night if you couldn't sleep, right? You know, and now you get up and look at your tablet and you're reading and it's waking you up and you don't even think about that it's doing that. So there's a lot more distractions and disruptions. And I agree, not napping during the day is another important aspect.
Read a professional journal at bedtime too. Knock you right out.
Some advice that could potentially be harmful. Some people don't want to urinate and they dehydrate themselves, which can create a whole new host of problems. So you have to kind of balance that, not wanting, so I just don't drink after 6 p.m. Well, I mean, that means you're not having any hydration in your system for 14 hours until the next morning. So that can be a concern. The other thing I was going to mention is magnesium can be a help calm people down. Every type of magnesium, sure. It doesn't work for everybody. Sure. Mm-hmm. Yeah.
I'm not a doctor and I don't play one at HACCP classes, but I do have an AI overview of the Tulsa procedure, if you'd like me to read that to you. Okay, it's the Tulsa procedure is an MRI controlled transurethral ultrasound ablation therapy used to treat prostate cancer and benign prostatic hyperplasia. It uses directional ultrasound to heat and destroy targeted prostate tissue while the patient is in an MRI, allowing for real-time temperature monitoring and precise control. This incision-free outpatient procedure is designed to preserve urinary continence and erectile function by selectively ablating cancer cells and sparing healthy surrounding tissues. And it goes on to talk about how it works, the preparation, planning, delivery, and confirmation.
Thank you for filling me in on that as well. The key word was does not involve an incision. It's a transurethral with focused ultrasound. And what will be interesting, I don't know how long they've been doing it, but we need some long-term studies to see how that works. But it's minimally invasive, which in a lot of the age group where it's being done is really important because you don't want to do damage or unnecessary. You don't want to overtreat it as well. So thank you.
In the corner.
I have a quick question. So does enlarged prostate by itself, with like PSA that has gone up rapidly? I've had MRI, it was negative. I had a biopsy, saturation biopsy, it was negative. I had a PSMA PET scan, it was negative. My prostate constantly growing, and they gave me the procedures. It could be steam therapy, it could be laser, they could shave the prostate. But the prostate being bigger, does it increase the chance of cancer, or are these unrelated topics?
No, I do not think it increases the chance of cancer. You should be proud. I'm being funny, but no, I mean, huge prostates can be benign. So, and I've seen years ago, PSAs in the 30s and 40s, put guys through equivalent to what you're talking about, and there is no cancer there. So you're monitoring it. That's the important thing. And if you're peeing all right, don't worry about it.
I think it's a concern that myself being in my mid-80s, mid to late 80s, that for some people, they can go to a physician alone. And yet, if they're a friend of ours, we know that they have serious issues, but they don't bring it up. And how important is it to have a patient advocate with the patient, whether it's a spouse? We always go in together, no matter what the issue is. When a patient just shows up alone, doesn't tell you the whole story, what do you do?
Don't know what you don't know. So that is a strategy that some patients use, not to tell us the story. A lot of times if they have a family member, it's a little more complicated because of HIPAA, but if you have a family member, you can talk to the doctor about the patient. They just can't talk to you back. So sometimes I did a lot of geriatric care too. And in oncology, that was a big part of wanting to have a second pair of ears. So people were forthcoming about how they were really doing, because in the oncology world, patients don't want to complain to their oncologist because they're afraid the oncologist then won't give them the treatment, and they want the treatment, right? So sometimes they're just not as forthcoming about all the side effects they're having. So having someone with them was really helpful. But we would get phone calls from family members just filling us in on the backstory, saying they're coming in, they may or may not tell you about this. Well, you know, you have to kind of delicately bring up the subject because most adults don't want their family members tattling on them. But you can also just phrase that, your daughter called, she's very concerned about you. Can we talk about what she's worried about? And usually then that will open the door to a more honest discussion. The real trick is if there's dementia. That's a really tough one because most people don't recognize their own cognitive deficits, or if they do, they don't really want to bring them up to the doctors a lot of times. And yet it's important for their safety and health to know what's going on with them mentally too. So anyway, I don't know how do you handle that, Bryan? Or
I certainly have my patients, I gently ask them to have a family member and a spouse, one of their children to be in with them so that when we're talking, I have a number of patients who have their children or a spouse and they're writing things down. They're just, taking a record of the things that I'm saying so that and that can help anybody really, because we only remember a fraction of everything that's said. A lot of times when I'm giving instructions to individuals, I'm writing that down on a piece of paper or something that they could remember. But there's some people who have family across the country. We have them on speakerphone. That happens all the time where, you know, they're there and they are there to ask questions and then just, you know, be able to fill in the blanks when the patient doesn't remember what was said. Well, this is what was said, Mom.
Do you have any other questions?
Well, I did want to mention to answer, you had asked a question before about not being able to get in to see your doctor. We have very limited resources and there's a general shortage of primary care physicians and actually many specialists. And especially as we age, we're not able to get in to see the physician. What I have found is that we have nurses that can operate at the top of their licenses and give advice, whether it's over the phone, whether it's, you know, phone triage, like in my office. And if it comes time to, I think you need more than what the nurse can provide, then we have potentially a physician assistant, nurse practitioner. We have a PA in our office and you can see them and they operate at the top of their license, which in a lot of cases can be very serviceable for common illnesses and diseases and processes and allow us to see maybe some of the more difficult things. But if the issue becomes more difficult for the nurse practitioner or PA, they do consult with me, they consult with the physician, and we can come up with a battle plan together collaboratively as a team. And then there are times that the person is just so complicated, many medications, they want to see the physician. I keep my schedule open. I think I only have 12, 13 patients that are in my schedule to start the day, and I get filled with my own patients who want to see me. And sometimes it's even just for a sinus infection, but that'll be another 11, 12 patients I see on top of that. Not every physician does that, but I do think that there's tremendous benefit for seeing the person who knows you. You remember the conversations you had before. You don't have to explain everything again. And as good as the electronic medical record is, you know, there's just kind of that, I've been there with that person. I know I know their family, I know their situation, and we can cut all that. There definitely is better care, but you know, there's only one of me. And sometimes we have to say, well, you know, Dr. Drozdowski's full, you need to go to urgent care or you need to see the PA. But the benefit of seeing a PA in my practice is they could still let me know what's going on. And sometimes I can just pop in and say hi and do that communication that way.
We have a question from Dan online. He says he was denied an MRI because of metal in his eye. Is there any way to shield the eyes from the magnetic field?
No. If you have metal in your eye, you cannot have an MRI because what will happen is they're putting you in a strong magnet and that magnet is moving and it will move whatever metal you have in your body. If you have a piece of metal in your eye, it will spin all around inside of your eye and could potentially destroy your eye. So that would be bad. And there's no way to shield from that. It's not like an X-ray where it's radiation. We can put a lead shield and shield it. The whole room is magnetized. You'll hear stories periodically of somebody going into an MRI room and has an oxygen bottle or a bed, the wrong thing. Everything that goes into that room has to be non-magnetic. If you bring an oxygen bottle in there, it'll become a rocket and it will oftentimes kill the patient. And so a lot of implants now are specifically made out of titanium or other non-magnetic metals, and to allow you to have an MRI, because that can be a big problem. You have a artificial knee joint, and now you need an MRI of your head for a stroke or something, and they can't put you in the scanner. So now a lot of materials that we implant have been made out of non-ferrous metals that are non-magnetic so that you can still have an MRI scan.
Doug, you made a statement earlier that you've had some patients in the past who had prostate cancer with a normal PSA. How was it? How did you determine that they had prostate cancer digitally or?
Yes, the digital exam did not I didn't think it was normal. And it took a little diplomacy to talk that patient into a biopsy because they said, well, my PSA is fine. I said, well, I've checked a lot of prostates. It just feels a little, I feel comfortable recommending this, so it's your option and so forth.
Okay, thank you.
I think we have time for one more, if anybody has one.
You had mentioned melatonin and another medication as being safe for sleep. What was the name of that second one? Trazana? Or?
Trazodone.
Trazodone.
Yes.
Trazodone.
Yeah.
Okay, thank you.
That it was initially marketed as an antidepressant. It didn't work as well as an antidepressant, but it put people to sleep. So it's like, which is a nice side effect for people. Just don't take it in the morning. That one is a lot less likely to be associated with dizziness. The side effects that I hear for patients, maybe some, you get dizziness, maybe some dry mouth, but sometimes it is still in your system and effective in the morning. So you have that hangover effect, and some people can get past that by maybe taking it a little bit earlier in the evening so that, you know, by the time morning hits, it's not as effective.
Oh. Jane has a comment.
Well, you know, your point about, you know, having a normal PSA and still having cancer. I mean, this is kind of the day and age of what we call tumor markers, and lots of people have had cancer, or know people have had cancer. And yes, in the oncology world, we follow those markers, but they are not 100%. So just because you have normal tumor markers doesn't mean you don't need to have additional evaluation and workup if the doctor's suspicious that you have malignancy, because sometimes the most aggressive of the cancers don't even make tumor markers because they're too primitive to secrete the proper marker.
Quick comment. So far, AI is not able to check your prostate.
Good point.
They have robots, you know.
They're going to come up with a probe to attach to your cell phone.
Hopefully it's heated.
Yeah, right next to the stethoscope. Okay, I think we have worn out our doctors. Please thank them. I hope you all enjoyed this session of HASP. It was really productive. Thank you so much.